Good morning, Ralph.
It's great to be here.
I'm speaking to Dr. Ralph Brindis, who has been the winner's lecturer, 23rd lecturer today, January 14th, 2016. Dr. Brindis is from California, San Francisco, works with the University of California in San Francisco, and it's a pleasure to have you here. And what we thought we'd like to do, Ralph, is just have a little conversation about some of the factors that enter into the practice of medicine today. You and I have been around long enough to know there have been huge changes as the years have gone by. Today you talked about the use of the National Cardiovascular Data Registry of the American College of Cardiology, which was a wonderful expose of how it operates and what it does. One of my questions to you is, how do you compare the effect of clinical trials on a database registry like the ACC has? What's the contribution of each?
Well, again, Bill, thanks for having me today. You know, the issue of the use of observational registries to inform us or fill our guidelines or understand practice of care compared to randomized clinical trials has been a hot topic. Clearly, the gold standard is randomized clinical trials, the ability to eliminate variables, assure that there are no unmeasured confounders when one does the studies. The high quality and integrity of the data will always make a randomized clinical trial the gold standard. The challenges that we have related to randomized clinical trials are the following. They're very expensive. No one can do a randomized clinical trial for under $30 or $50 million. Huge time sinks. It's a big deal. And the other trouble that we have as clinicians related to randomized clinical trials is that they are going to fit the agenda of the people who are funding them. So most of the funders of randomized clinical trials turn out to be industry, so they're going to, not in a bad way, look at things that would help foster, their own personal agenda related to what their companies are. And that oftentimes is very valuable for us clinicians, but there are a lot of gaps or holes in our evidence base if we simply relied on industry-based randomized clinical trials. So the observational registry, such as the NCDR, has been very informative. And we look at the observational data, our randomized clinical practice guideline task force, our task force of clinical practice guidelines, ask clinical questions, and drill down in our observational registry, such as the NCDR, help inform us. The challenges there are the confounders. So the new paradigm is actually taking the infrastructure of observational registries, the 1,600 hospitals that we have, and build inside them true randomized clinical trials, where you therefore can eliminate the confounder issue, can enroll patients quicker, can see patients in the registry that have all sorts of comorbidities. You can have a larger enrollment base, and you can do it much cheaper. So that's a very exciting new development. The challenge is the issue of the data integrity, which we think we do pretty well with.
So basically, the two techniques, the clinical trials and the data registry, they really complement each other, and they really need each other.
I totally agree with that.
With one without the other would be a little bit less than whole. Okay, so in that regard about the information, is information that my question now is for young people entering the field of medicine. Two questions. What do you think their expectations and are now, And does the information that comes from the registries and the clinical trials, is it being incorporated into the medical school curriculums in any way?
Well, there are a lot of great thoughts and questions in that particular one. First of all, I would comment to young people going into career medicine or a career in cardiology. I'm jealous. So this is a very exciting time to be a young clinician. The advances are amazing.
I'm so glad you say that, because I hear so often older physicians say, don't go into medicine. It's not going to be a good profession in the future. I don't know how they could be more wrong, but go ahead.
No, I totally agree with that. I think it's a very exciting time. Now, but a new physician needs to understand, and a lot of them do. They're very quick to learn, much quicker than us, on how a physician fits into the new order of healthcare, where healthcare is now under as team-based healthcare, the intersection with data as an information tool to help inform us of best practices, the utilization of electronic health records to help you as opposed to some of us who are worried about it hindering us, and so forth. So, and then also understand the environment related to how we're being reimbursed, this going from volume to value. And I think the modern new clinician gets it. They want to be good stewards of the healthcare dollar. They understand that we shouldn't be doing low-value tests or low-value procedures to patients, and are looking for guidance, if you will, and the registry can help with that, along with all the other guidance that we have through other quality tools through the ACC, and to be able to be more effective clinicians in that manner, better stewards of our healthcare dollar. So that's different.
You know, I read just the other day in an ACC publication that the use of the publication of appropriate guidelines has resulted in a major drop in inappropriate use of technology. That's terrific. That's a major step forward, because we always worried about particularly imaging studies that can be done in the office where anybody can do them, and good, bad, and indifferent. But
I'm very proud of that particular work. Came out of Yale, published in JAMA, looking at revascularization of appropriateness over a 5-year period and the changes over time. Now, a cynic could say the improvement in decreased inappropriate angioplasty could be due to 3 reasons. It could be due to just better documentation, which I think people are better documenting of what they're doing. It could be due on gaming, people gaming the system to say something's appropriate or not. Or it could be due to real improvement. And the reason why I agree with you in particular that a lot of this is due to real improvement is that the actual volume of elective PCI over the last 5 years has decreased 30 to 40%. Yeah. So that shows that we've become better stewards of the healthcare dollar, which I think is more patient-centric.
Yeah. Let me ask you another question. You've been in this business a long time now. If you were to look back over your career, looking at where you are now, what you know now, how would it have affected your decision along the line as to what you do?
You know, it's a great question. It is amazing how one's career path is, a lot of it is related to serendipity, just being in the right place at the right time or whatever. So when asked this question by young cardiologists, you know, what should they be thinking of at my stage of the career? My first comment is, first thing you should do is make sure that you get really good at your craft. You know, take care of patients, get in the trenches, work hard, and enjoy being a cardiologist. And then the next thing is to participate in external activities, whether it be educational forum as a member of steering committees, but also get involved in professional organizations, whether it's the ACC or the AHA or whatever. And then the last thing is find a mentor. Because mentors turn out to be incredible, helpful, not only in terms of giving advice and reflecting with you what you're doing, but in many respects helping you in what I call connecting the dots. The mentor knows people somewhere and knows your skills, and there's no better thrill for me as a mentor, and I suspect yourself, is connecting two people together, making a win-win. It's the best thing that I do. And then when one does these endeavors, my comment is show up. You know, how often did you see, is when you were president, people on committees who don't even bother coming? So first you,
Yes.
you got to show up, be present, be involved, work hard, be selfless and humble. And then it will be amazing what you'll be able to achieve.
Well, I think my thoughts go along exactly the same line as yours. When I look back in my career, serendipity has played a huge role, as well as role models and mentors. And I didn't really appreciate that when I was younger, but I do now. I don't believe anything can be more important than having really good role models to follow and mentors to help you along. And then good things happen, and you have to have the courage to take advantage of opportunities that come along and recognize what's a good opportunity, what's a bad opportunity. And then when last fall, Susan had me do an interview, and one of the questions was, you know, how do you treat patients? And my response to that was, the quicker you establish a rapport with a patient, the better off everybody's going to be. So I endorse your comments. Just couldn't be more on the mark.
Well, thank you.
So let me thank you again, Ralph, for coming today. It's been a pleasure having you here, and we hope we'll have you back again one day.
I'm happy to come for your 100th birthday lecture.
That's a deal. We'll set it up now. Okay.